Hi everyone. This week, week 2 of our cardiac education is atrial rhythms. So first we're going to talk about premature atrial complexes or PACs. They're mostly benign, so they don't cause anybody any trouble, but they do begin in the SA node. On the EKG, it looks like a beat appears before a beat should appear, which I know sounds funny, but when you see it on a strip, it will make sense. And then it's followed by a normal or a wide QRS complex. If it's not conducted through the heart, you will have an abnormal P wave not followed by a QRS. It can feel like skipped heartbeats. The patient can sometimes say they feel like they're skipping heartbeats. And common reasons for this would be CHF, cardiac ischemia, PE, fatigue, digitalis toxicity, hypokalemia, hypomagnesemia, excessive caffeine, tobacco, alcohol, or stress. Who doesn't have stress, right? So when we break it down, I like to make things simple, especially when we're looking at EKGs because they can be so complicated. We look at a couple of different things. One of the things we look at is the rate. So with PACs, your rate is usually normal, but it can vary. And then we look at our rhythm. It's regular, meaning it happens at regular occurrences, but there are those premature beats that will show up. We look at our P wave, which again is premature, and it differs in shape from a sinus wave. Our PR interval will be variable. It will be from 0.12 second to 0.20 seconds. And then the QRS complex is less than or equal to 0.12. And it may be prolonged if there's abnormal conduction. So this is what it looks like on an EKG strip. You can see that circled area there is that premature complex. So it looks like a beat is trying to happen, and it was stopped. Next, we're going to talk about supraventricular tachycardia, SVT. I think just anecdotally, we see this pretty common in labor or in pregnant patients in general. It is a rapid heartbeat originating in the atria. Your P waves may not be visible. You have a narrow QRS complex because it's happening so fast. It can be paroxysmal because it can come on quickly and go away. It doesn't necessarily have to be for a sustained or prolonged period of time. It can be kind of fleeting, which is fun, right? So some of the causes can be physical or psychological stress. So hello labor, those patients that are laboring or they're going through some sort of psychological stress, it can cause the heart to emit this kind of rhythm. Hypoxia, hypokalemia, excessive caffeine, nicotine, any other stimulants, rheumatic heart disease, coronary artery disease, MI, myocardial infarction, mitral valve prolapse, DIG toxicity, and respiratory failure. Again, breaking it down, trying to make it simple. So your rate is going to be anywhere from 150 to 250 beats per minute. That is fast. Your rhythm is going to be regular, so it does come at regular intervals. Your P wave may be seen or it may be hidden. Your PR interval, 0.12 to 0.2 seconds, or it may not even be measurable. If it's happening so fast, that interval may be so small that you might not be able to measure it. And then your QRS complex is less than 0.12 second, so a fraction of a second. And this is what it would look like on an EKG strip. So you can see that rate is super fast. And then they have the P wave that's actually visible. Next, we have our multiform or multifocal atrial rhythm. It's also known as a wandering pacemaker. It is an irregular rhythm. It doesn't happen at regular intervals. And the impulses originate from various sites, which is what makes it look a little bit chaotic. There are multiple different shapes of P waves, which is fun because you're trying to decipher, is this a P wave? What is this supposed to be? Some of the causes are digoxin toxicity, rheumatic heart disease, atrial hypertrophy, acute MI, and COPD. So again, when we break it down, try to make it simple. Our rate is going to be 60 to 100, which is a normal rate. We wouldn't expect anything to alert any sort of red flags. If it's greater than 100, that's a multifocal atrial tachycardia. So it has another definition if the rate is greater than 100. Our rhythm, for our atrial rhythm, it's going to be irregular. And then for our ventricular rate, it is going to be regular. So that's fun. Your P wave is going to be different shapes and sizes. And you need at least 3 different shapes and sizes for it to be categorized as this rhythm. Your PR interval is variable. Your QRS is less than 0.12. It may be wider if there is a ventricular problem. So here's what our multifocal atrial tachycardia looks like. So you can see our different P waves are kind of messy. It doesn't look consistent. But our QRS complexes are generally regular. Next up, we have atrial flutter. So that's when our atria fire at a rapid rate. We'll see a sawtooth pattern on the EKG strip. Your ventricular rate, if it's less than 100, that's a controlled atrial flutter, meaning that your ventricles are able to sort of keep up with the disorganization of the atria. It's trying to keep everything under control. If your ventricular rate is greater than 100, that's uncontrolled. So your atria are misfiring, your ventricles are trying to keep up, and they just can't handle the chaos. That's kind of how I like to think about it. Some things that can cause this: acute MI, mitral or tricuspid valve disease, PE, hypoxia, digitalis, or quinidine toxicity, or quinidine, potato, potato. Again, break it down, make it simple, right? Make it easy. For our rate, the atrial rate is going to be between 200 and 350. So as you can see, that's extremely rapid fire. And your ventricular rate is going to vary depending on if it can keep up or not. Your rhythm, your atrial rhythm is going to be regular, but your ventricular may or may not be. Your P wave is not visible. It's just chaotic. Your PR interval is not measurable. And your QRS is less than 0.12 second. So there's your atrial flutter. So you can see that sawtooth pattern in between the QRS complex. So that's your telltale sign for atrial flutter. Our next rhythm is atrial fibrillation. That's when the atria are quivering and not effectively contracting. So with atrial flutter, they'll contract, but it's disorganized. With atrial fibrillation, the atria are just kind of like quivering and shaking, and they're not effectively contracting and pumping the blood. So your ventricular rate here, again, if it's less than 100, it is a controlled AFib. If it's greater than 100, it is uncontrolled. Again, because your ventricles are trying to keep up, and then eventually they get to a point where they just can't. Some of the causes: acute MI, ischemic heart disease, mitral or tricuspid valve disease, hypoxia, digitalis or quinidine toxicity. And I like this visual because it shows the difference between atrial fibrillation and atrial flutter. So you can see atrial fibrillation in between those QRX complexes is kind of a lot of just like, it looks like little spasms that are happening. And then your atrial flutter, you can see where the atria are trying to do what they're supposed to do, but it's just not regular. It's a little bit chaotic. With our AFib breakdown, your atrial rate is going to be greater than 350. Your ventricular rate is going to vary, again, if it's controlled versus uncontrolled. Your rhythm, ventricular, is going to be irregular, and your atrial is also going to be irregular. Your P wave is not visible, it's just that fibrillation, right? Just that little spasm on that EKG. Your PR interval is not measurable. Again, if you don't have a P wave, you can't measure your PR interval. And your QRS generally is going to be less than or equal to 0.12. And lastly, we have Wolff-Parkinson-White syndrome, which is also known as a pre-excitation syndrome or bundle of Kent syndrome. And this actually develops in utero. So when we're in utero, our connections in the heart go from atria to ventricles, and they kind of do this cyclical motion. In Wolff-Parkinson-White syndrome, that pathway doesn't end. It doesn't get cut off at birth like it would normally. So it conducts your impulses faster than what your AV node normally would when that process takes over at the time of birth. So with Wolff-Parkinson-White, you'll see a short PR interval, a longer QRS complex, and that will give you a delta wave, which is actually kind of cool to see. Your patient may or may not be symptomatic. If they do have symptoms, they may experience dizziness, palpitations, weakness, anxiety, fainting, chest pain, or shock. Going with our breakdown, your rate is going to be 60 to 100 as long as your underlying rhythm is a sinus rhythm, right? So most of the time that's going to be the case, but you might have a fluke where they have some kind of irregular rhythm. Mostly your rhythm is going to be regular. Your P wave is going to look normal. Your PR interval is less than 0.12 seconds. QRS, it's commonly greater than 0.12 second, and you will see that delta wave. So here's a couple of different visuals for the Wolff-Parkinson-White syndrome. So the top one, you can see how that QRS complex starts going up, and it looks almost like a wave that's starting. There's almost like a rounded edge to it. That's your delta wave. So if you're not really paying attention, it can look a little inconspicuous at first until you have a trained eye to be able to look at it. And then this bottom visual image, it really shows you that curvature of the delta wave, and that dotted line shows you what your QRS complex would look like had there not been a delta wave there. Really interesting, really cool visuals for Wolff-Parkinson-White syndrome. And there are my references. So that concludes week 2 of our cardiac series, atrial rhythms. Stay tuned for more. Thanks for listening. Bye.